college and university athletes in Jamaica. My supervisors are Professor Alan Asamoto and Dr. Donovan McGrowder. Second. Okay, let me get this right. All right, good. So, our protocol will be, we look at the introduction of biological passport, overall aim and specific objectives of the study, portion of the methodology, some results, discussion, and conclusion. So, before we begin, what is an athlete? Who is an athlete? An athlete is defined by any person who competes in sport at the national level, as defined by each international federation, or the national level, as defined by each national anti-doping organization. What is biological passport? Essentially, it is an electronic record where biological markers and proof are profiled. Blood and urine samples are taken over a period of time, and specific markers, hormones, etc. are identified. It is based on an individual and longitudinal monitoring of hematological or urine markers. Biological markers of doping is essentially to find the signature of doping in the biology of the athlete. So traditionally, we would look for the banned substance, but for this protocol, we look for the physiological change that takes place as a result of substance being used. So the ABP is based on changes again in biological markers collected across the athlete's career, rather than on the detection of specific illegal substance, as I said before. And as a result, athletes can be tracked by constantly interpreting passport data. What currently happens in the world of ABP? Well, in Jamaica currently, it is not established as yet. However, traditionally, what we have is our national body, JADCO, that will collect samples and test samples for exogenous source and so forth, which is the traditional way. But regarding monitoring of athletes' parameters, that is not yet is done in Jamaica or in the Caribbean region. However, in the world, in more advanced countries, it is done, such as countries like Australia, England, Germany, USA, of course, Switzerland, etc. So what it entails really is that this chart gives a pretty much overview of what it is about. So you have your international federations or your national anti-doping associations. For in our case, that would be JADCO. Once an athlete is considered, national representative and so forth, he or she is placed in what is called a registered testing pool. So at any moment, any time, a doping control officer or a blood control officer can, notify the athlete where they are, and a sample can be collected. Once that is done, the samples are transported in controlled temperature and is brought to the lab and is analyzed within 36 to 48 hours or less. Once that is done, as you follow the track, the results is being analyzed by 3 experts. And if you notice over here, you see minimum 4 to 6. So in some cases, they will take 4 to 6 samples throughout the year, or as much as 9 samples throughout the year, and analyze such data. 3 experts will evaluate the results, and if there is a adverse passport finding, then it is reported to the ADO management system, and then the athlete will be notified. So in essence, that's what it is. So in sports medicine, laboratory medicine is becoming increasingly important in assessing and monitoring an athlete's health. Acute or intensive exercise, as prescribed by professional athletes, can result in infections, inflammations, muscular injuries, or cardiovascular diseases, which can be difficult to diagnose because the athlete is not constantly being monitored. The absence of such monitoring can have major ramifications for professional athletes' recuperation. These imbalances can cause metabolic adaptations, which can result in changes in specific concentration and activity indices. The hematological profile can detect blood manipulation, for example, whether EPO has been taken, whereas a steroidal profile can identify whether exogenous steroids have been taken, for example, testosterone. Individual hematological and steroid profiles allow the permanent monitoring of variation in an athlete's biological parameters. Abnormal variation can be considered as proof of doping, even if no limit has been exceeded. Controlled medical doping with fixed limits then becomes too risky for the athlete to cheat. Okay, so the objective of this study is to evaluate the hematological and steroidal markers for college athletes participating in track and field, volleyball, cricket, football, and netball, to determine the relationship between variation in specific biomarkers before, during, and after competition. So, for the hematological marker, these are some of the markers at the top that we look at, and for the steroidal marker, at the bottom, that's what we look at. So we look at the hematocrit, hemoglobin, cells count, percentage of reticulocyte count, mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration. And for the steroidal aspect, we look at testosterone, total testosterone to be specific, human growth hormone, dehydroepiandrosterone sulfate, and estradiol. And I'll explain some more about these markers and the importance of it. So, ethical approval was granted by UWI and University Hospital of the West Indies. Interviews were conducted with the coaches and prospective participants. Questionnaire design to collect demographic data was used. Sample collection, analyzation, and storage was done. So the research design is pretty much a quantitative study of approximately 64 athletes, where samples of blood and urine will be collected, or was collected rather, from athletes competing in several different sporting disciplines. Blood and urine samples were rather assessed for specific biological markers using Cobas 6000 analyzer, while hematological parameters will be analyzed, or was analyzed rather, using the cell dyne Ruby 2 at the subdepartment of hematology. So with the urine collection, athletes is given a choice of sample collection vessel and other sample collection equipment from which to select. The athlete and researcher investigator will check that all sample collection equipment is clean and that all seals on the selected equipment are intact and have not been tampered with. After the athlete has selected his or her sample vessel, he or she retains control of the vessel until the sample is sealed, unless assistance is required by reasons of athlete's impairment. So the method in collecting urine and blood strictly follows water rules. Blood collection, for the purpose of measuring the hematological parameters of the biological passport. 2 tubes of 3 milliliter containing EDTA as anticoagulant labeled A and B. It's collected. Samples can be collected 2 hours after physical effort, whether training or competition. The athlete must remain seated for at least 10 minutes prior to proving a sample. The athlete should be questioned about specific issues like altitude, natural assimilated blood losses, donation, or transfusion. Okay, so we have 2 groups of athletes and 2 groups of discipline that we divided. And in group 1, we looked at footballers and sprinters and netballers. The red arrow indicates elevation, and the blue arrows indicate low measure in terms of the reference range. So on your far left here, right rather, you will see the reference range for each of the hematological marker. And what you're seeing here is this particular athlete, who's a footballer, has 2 markers that are 3 markers rather, that are elevated above the reference range, and also have 2 markers that are below. So the color green is competition phase, and the purple represents preseason. So what we're seeing here is that the hematocrit level for this athlete has been elevated during competition. There's a lot of elevation during competition, but for 2 of the markers, which is mean corpuscular hemoglobin, they are low. Mean corpuscular hemoglobin concentration is also low, and I will explain what that means. For that same person, we look at the steroidal profile for that person, and essentially everything is within normal range in this section. Point to note, however, that human growth hormone, there wasn't any result in the competition phase for all the athletes, and the reason for that, and you may see that going through the presentation, the reason for that is because at the lab we ran out of reagents, so we couldn't test that, but the samples are stored and they will be tested in due time for us to get the competition reading for that particular time. So this athlete is pretty fine where steroidal is concerned. This is another athlete, which is a sprinter, just 1 marker that is elevated. Pretty normal where the steroidal is concerned. Everything is within reference range. That's a sprinter. This is another sprinter. 2 elevation. Everything else pretty much normal except for red blood cells distribution. Within the off season, there was below reference range. Again, steroidal marker is pretty fine for that person. Let's look at some netballers, and very interesting, you'll see some similarities coming out. So a number of the markers are low during competition and also in preseason. You will also realize that one of the steroidal markers is low while one is high. And again, I will explain what is taking place there later on. This is another netballer. Again, 1 elevation and a number of markers that are below reference range is seen. Again, testosterone is below what is normal. Everything else is pretty normal. Again, a number of markers are low on the hematological side. low testosterone, but elevated estradiol marker. Again, number of hematological markers are low, both pre and competition phase. Testosterone low, however, for this person, they have elevated estradiol and growth hormone in their system in the preseason. Still on netball, number of hematological markers are low. Steroidal marker, testosterone is low. Again, high elevation between estradiol and growth hormone. Okay. We have elevation here, still on netballers, and below reference range. Again, below reference range for testosterone. Similar, still on netball. Again, similar results. Let's have a look at that. Throwers. Again, low test again, high estradiol. Low hematological markers, those two. Again, low test, high growth hormone, human growth hormone and estradiol. For this person is a distant runner. Pretty normal. Low test, high estradiol again. Okay, let's look at some cricketers. We have a few elevation, again, and two markers that are below reference range. Human growth hormone is below reference range for this cricketer. Still on cricket, we have a number of elevation and a number of markers that are below reference range as well. So things are happening here. Normal steroidal marker, still on cricket, elevation and also below reference range. Pretty normal steroidal status. Let's look at some volleyballers. Yeah. So we have two markers that are below reference range, pretty much normal steroidal profile. Elevation for this person, one below reference range, pretty normal steroidal profile. Okay, so what does that mean? So this chart will show a comparative reading between the hematological parameter and steroidal parameter. So all the markers that are high are on the side and the ones that are low on this side. The discipline are in order and also in sex. If you look closely, you will realize that the netballers, as you see in the graph, that they have similar elevation or markers, or excuse me, below reference range. All right. So what does all of that mean? So 18 athletes were reviewed from 7 different disciplines. Okay, so hematological and steroidal parameters were analyzed in the off phase again and competition phase, as alluded before. So the parameters that were high, we see we were 38%, or 7 of the athletes had high hematocrit. 16% had high mean corpuscular volume, 4%, 22%, or 4 had mean corpuscular hemoglobin, red blood cell distribution with platelets, 5% that was high. On the steroidal aspect, 7 of the athletes had high estradiol and 3 had high human growth hormone. And on the lower portion, 55% had low testosterone, 1 had low hemoglobin, and as you can see, the hematological markers are, you know, substantially low for many of them. So, as you know, as you may or may not know, that hematocrit, percentage of red blood cell, main function of red blood cell in exercise is to transport oxygen from the lungs to the tissues, and the delivery of metabolic produced carbon dioxide to the lungs for expiration. Abnormal high hematocrit can be sign of dehydration or congenital heart disease, while an abnormally low one can be seen or sign of nutritional deficiencies or being a well-trained endurance athlete. And evidence has shown that athletes who do long distance running tend to have low hematocrit. High hematocrit signifies high blood viscosity or the thickness of blood, which causes it to flow more slowly, while high volume of red blood cell is the hallmark of athletic performance and high aerobic capacity. Estradiol is one of the primary forms of estrogen during reproductive years. The results indicate high estradiol levels, which may be due to medication or health abnormality. Injury risk might be higher for women normally exposed to high levels of estrogen. The effects of chronic estrogen exposure might also help to explain some of the differences in tendon mechanism properties and injury rates between male and female athletes. On the low metrics in the result, where we see a number of results, testosterone that were low, again, testosterone, one of the most potent naturally secreted androgenic anabolic hormone. In muscle, it stimulates protein synthesis with an anabolic effect and inhibits protein degradation with an anti-catabolic effect. Traditionally, this compound has been abused by elite athletes to achieve these anabolic effects. In women, although testosterone is not generally considered to be a primary anabolic hormone, it nonetheless has a powerful effect on muscle tissue. In fact, recent double-blind randomized placebo-controlled study investigated the effects of moderately increased testosterone concentrations and physical performance in young women, finding that supplemented groups showed increased performance and muscle strength. Testosterone is the main protective factor against muscle damage and fatigue after severe exertion. Females in this study express low testosterone levels, which may be more prone to injuries due to weaker muscles and tendons. Mean corpuscular hemoglobin concentration describes the level of hemoglobin in your red blood cells. Having low levels of MCHC is indicative of anemia. It could also signify low iron, inflammation, or hemolysis. The result shows a significant portion of the participants expressing a low level of mean corpuscular hemoglobin concentration. So, conclusion. Although the athletes do not significantly differ in their levels of most parameters, these groups are characterized by different patterns of changes during the different phases. Our results suggest that when interpreting the values of hematological parameters and steroidal parameters, specific phase should be taken into account. Results shows that most parameters decrease during the competition phase as well. Next step is athletes will be monitored for another year, where hematological and steroidal results from year 2 will be compared to results from year 1. And these are just some of my references that were used. Thank you. Any questions? Let me just go back.
Thank you very much, Mr. Miller. Very well presented. Interesting. As you said, we're open to questions. I'm not sure if anyone has any questions. If so, you could just use the raise your hand. Okay, David Riley. You
really.
have a question?
Yes, good evening. Good afternoon. I have 4 questions. And I don't want to seem like I'm attempting to bombard you, but I think this may be my first opportunity to ask questions related to this particular topic. The first one I have is in relation to what really are the disagreements within the scientific community on the use of the biological passport in sports. The first one.
Okay, so thank you for that question, Mr. Riley. There are some arguments, there are some confounding factors that may affect the reading of, for example, your hematological markers. There are certain things that may throw it off. For example, we look at athletes who have certain disorder, which may or may not know, they may or may not know that they have this type of disorder. That may affect the markers of the hematological profile. For example, anemia. Many of our athletes, especially females, tend to have this issue, whether it's from a nutritional aspect or some other things at play. So some of the conversation is that there are certain things that may, for lack of a better word, mess with the interpretation. And there are certain things that should be looked at before a judgment is being made. Because again, essentially what we're doing is looking at the upper limits and the lower limit of a specific marker for an athlete. And while plotting that, going along the way, some argument is that there are certain things that can cause an elevation or that can cause a drop. And so it is said that these are some of the confounding factors that must be taken into consideration. So we have athlete disorder, we have athletic characteristics. I mean, every athlete is unique. We have to look at the gender. We have to look at the ethnicity of the athlete. Also, for women, of course, the menstrual cycle plays a part of that as well. We also have pre-analytical factors, before taking the sample, what kind of condition that athlete was in. Was that person dehydrated? Was that person performing at an elevated plane? Things of that nature. So that is why certain questions must be asked and answered before a judgment can be passed. And that is why there are 3 experts or more engaged in coming up with a judgment. And these experts ranges from a pathologist or endocrinologist and a clinician and so forth. So yes, there are some arguments against it regarding certain factors that may influence the reading. And again, that is why it is important that a number of tests throughout the year is being taken and taken over a period of time so that we could spot a pattern.
All right, so I mean, you've said a couple of things that would have almost segue or tried to answer my other questions. One has to relate to how many of the markers are race related or due to dietary realities of the athletes. That's also an issue. Maybe you want to speak to that as well.
Yes. Right. So again, anemia is a really big issue right now among our athletes, especially the females. And dietary consumption plays a critical part of it. I can tell you, some of the markers that I showed right here is just a very small portion. We test for a lot of other things that could indicate or specify that, yes, this person, iron level is very low, significantly low, and things of that nature. Yes, it is important, and it does have an effect on the mass and on the markers. It does, because if somebody is deficient in a particular nutrient, it can be seen. It will have influence on different metabolic functions as well, which will in turn, influence performance or functioning. So yeah, it is extremely important and influential.
All right. Next question. How do you distinguish elevated from increased? Is there a percentage that you're looking for to describe or define as the elevated levels? Okay. Or is it any increase that you consider to be elevated?
Okay, so two things. Naturally, we have, as I showed in the presentation, a reference range for normal people. No, athletes are not normal people. We know that. Their ranges might be a little bit different in some regards. So over a period of time, by having doing multiple testing, we can plot specifically for that athlete and say, look, over the 2 years, we have realized that you're at X with this marker, and you fluctuate between, a certain percentage point during the 2 year. So based on the reading from that specific athlete, we will determine that person's upper limit or lower limit. And with that, going forward, that the person's profile will be their, what's the word I'm looking for? It will be their
standard, which you're comparing.
Their baseline.
Yes, it would be their standard. And as I said, it's an individual profile. So we will make the judgment from that perspective, because the standard is based on them.
My last question.
Mr. Riley, can we get someone else?
Sure, go ahead.
We don't have a lot of time. We have 2 other persons waiting to ask a question.
All right.
Can we ask Ms. McIntosh, can you go ahead and ask your question?
He indicated that there were three experts reviewing the samples. Who are those? Who are the experts?
Right. So as I said, the endocrinologists, the pathologists, depending on what we find with the athlete, the expert in that area will be called upon, along with a sports medicine scientist as well, our doctor.
Okay, thank you.
So whatever issue, the hormonal, the steroidal aspect, of course, the endocrinologist would be, there with that. So whatever region we find the issue with, we get the expert for that area.
Dr. Brown, do you have a quick question? And then if we have time, we could get Mr. Riley's last question in.
All right, I'll try and make it quick. So, yes, Mr. Miller. Well, one of the questions was maybe a suggestion. So, of course, all the ballers, presumably will be female, but you indicated that as well. Of course, all the sports would have both males and females. So, I'm just curious, how do you account for gender differences among the athletes, especially with the steroidal hormones and so on, or did you account for that? And then similarly, how do the netballers in particular, as a group, compare to female athletes from other sports? Or I don't know if you look at that.
Right. So good question, Dr. Diallo. That's something that we are eyeing as well. And what I realize, again, with every sporting discipline, there's always an ideal body type that suits that discipline. And training over a long period of time will, of course, alter your body chemistry and physiology to an extent. So what I've seen is that a netball parameter is different from what will show from a female thrower or a distance female.
Right. Okay.
So we'll be looking at the differences between discipline and we'll also our trends, and we will also be looking at the similarities within the discipline itself.
Right.
You know, and once we get these results, it will definitely inform, you know, certain decision regarding how you train, what you eat, how you train when, and so forth, like that, and things of that nature.
Right. And that kind of alluded to the point I was going to make as well. I was saying that comparing those athletes now to, or comparing, let us say, what we call strength power athletes, so your throwers, the powerlifters, maybe even the bodybuilders as well, comparing them to other athletes, like endurance athletes or the other team sports and so on. So that sounds like that would be interesting comparison as well.
Right, right. And to be honest, you know, there are certain things that I've seen that jumped out, you know, at me. Athletes in similar discipline tend to have, you know, similar markers, not at the same level, but they tend to have, if, for example, the throwers, if they have high estradiol, I mean, all of them have it, you know, are normal. So there are certain similarities among them, not the same amount, but in general, it is pretty similar.
And so even across genders within the same discipline, are they still similar?
No, it's within gender. It's within gender.
Okay. All right, Dr. Diallo, continue there.
Yeah, man, that's fine.
We have 2 minutes. Mr. Riley, you think your question can be answered in 2 minutes?
I think so. Question.
Last question.
Are you, as a scientist, comfortable with the use of the biological passport to determine if someone is cheating or not?
All right. Good question. So, there's many ways to answer that. As a nation, we are, you know, dominant. We are on the scene. We're ruling where performance is concerned and so forth. And I believe that when it comes to testing and protecting the legacy of our people and our athletes, that should be our responsibility and not the responsibility of other nations. So yes, I feel comfortable with it, but again, it is not the only tool. It will be just one of many other tools that will be used to protect the Jamaica brand. So yes, I am comfortable with it.
Thank you very much, Fabian Miller. That's very interesting. There have been a lot of questions answered. We've all been, our eyes have been open to the possibilities that can be gleaned from your research. And I'm sure we're going to be looking forward to the results when everything is finished and as you move forward. Thank you very much. Thank you for all of the questions. We're now going to move on to what we, just a little information coming out of Jamaica Association of Sports Medicine in terms of an outreach, which we are doing, something that was initiated this year and which we hope will continue. And I'm going to ask Dr. Rochelle Calvert to present for Dr. Wendy Peart-Brissett, who is unable to do the presentation herself today. Just a quick note, congrats to Wendy on the birth of her little baby boy. So Dr. Rochelle Calvert is going to present on behalf of Dr. Peart-Brissett. Go ahead for me, please.
All right, thank you so much, Joan. Good afternoon, everyone. All right, so this afternoon I'm tasked with presenting the link, which is an initiative by the Jamaica Association of Sports Medicine. Now, what is the link? The link was generated, an idea generated to forge a partnership between the Jamaica Association of Sports Medicine, the JASM, and sporting bodies in Jamaica. So the rationale behind the link is that, you know, it was observed that smaller sporting bodies did not have designated sports medicine personnel that worked directly with them and their teams during the training cycle, during local and international competition. Now, during these instances, athletes would have competed with undiagnosed medical and physical injuries that would put them at risk for further injuries or, you know, complications. Additionally, many of the athletes would become dependent on the medical staff or the sports medicine team that traveled with them at these events. And This led to little or no time to provide the appropriate treatment and the follow-up. So this kind of put the medical staff and the athletes themselves in a dilemma where random persons, random medical professionals would be asked at last minute to travel with these persons overseas, and they would have little to no knowledge of the medical or physical history of the athletes. And this poses a problem. So this was the rationale or the basis for developing the link. And how exactly is it that the JASM will help in forging this relationship? Well, to bridge this gap, the association provides a wide cadre of highly trained and educated sports medicine professionals with years of experience. And their role is to become or bridge that gap to form a link between the athletes and the care that is provided while they are representing their country and doing so in a safe manner. All right, a part of the professional or the expertise that we do have as an association include medical doctors, sports medicine physicians, sports physiotherapists and physiotherapists, massage therapists, nutritionists, psychologists. So that is the wealth of experience that we as an association provide. And we want to ensure that we have these smaller or these other sporting bodies without that established link to know that they have our support and in bridging that gap. Sorry, my slide is not advancing. All right, so what can we offer as an association? So generally, the medical doctors and the physiotherapists are able to, we want to be able to attend at least one training session per week. 2, to offer on-site treatment and advice during the training sessions for acute injuries. We also hope to be able to provide ongoing treatment for acute and chronic medical or physical injuries. And of course, this would generally be done offsite and most likely at a cost. So that is something that would have to dialogue between the individual and the athlete or the team. We also hope by forging this partnership to be able to assist athletes with obtaining their pre-participation medicals and physical screening, as well as follow-up treatment that is needed as a result of things that might be identified during the screen, as well as being the point medical person for the particular sports team for local, regional, and international competition. So what are the benefits of the link? As said before, we will be able to provide medical care for those athletes who otherwise would not be able to get that standard of care, or for whatever reason they don't have access to that form of care. Additionally, for the members of the association, it provides an invaluable it will provide invaluable experience in working closely with the sporting organization and the athletes on a more consistent basis, and learning the ins and outs of the sports, the biomechanics, how in recovery techniques, etc., and becoming familiar with the athletes prior to travel. So this is a benefit that it will offer to members of the association. So how can an organization become involved, or how do we start the process? Well, a member of the JASM Medical Liaison Committee will collate a list of the national sporting organization and contact them to ascertain their need. So if there's a need, then we'll look at that need and essentially try to pair up an executive an organization member with the sporting organization to form that link, right? The executive of the association will then invite members to participate in the initiative and conduct workshops to the members. So through this workshop, we hope to introduce members to the initiative, explaining the idea behind the concept and what would be expected of them when they do partner with the sporting organization. It will also teach the participants how to prepare themselves for work and traveling with a team, as well as to help them to conduct pre-participation examinations. The participating sporting organization, as said before, will be matched to the trained JASM member, and then the relationship and the collaboration will be formed at that point. Now, in terms of some finer details, specific details such as stipend, if any, the provision of medical supplies, meals, transportation costs for attending training sessions, that will be worked out between the individual and the sports team. The JASM will not advocate for stipend because, you know, we are a volunteer organization, but the purpose of the link is to provide the experience and the opportunity for our members. So if there's any discussion regarding stipend, as said before, that will have to be communicated between the individual personnel and the team. For regards to ongoing treatment outside of that training session, this can be provided at the individual's private practice or place of work, and generally that will attract a fee. Again, the amount will be decided between the individuals and the sports team. Now, pre-participation screen, that is generally a medical and physical examination that will attract a fee from the individuals. Again, that arrangement can be decided upon by the parties. Referrals to other medical professionals, whether a JASM member or otherwise, for things such as x-rays, MRIs, nutritional consult, again, will be worked out between the individuals and the teams, and the cost will be borne by the athlete or the organization. The JASM will also suggest, if it's not already in place, that the sporting bodies apply for the national insurance program that the government offers to our national athletes to offset the cost of whatever treatment, medication, or other medical expenses that might be incurred. So that's it for the link. I hope that you know, as members, we will jump on this initiative, and as sporting organization, we will reach out and, you know, take advantage of what is being offered through the Jamaica Association of Sports Medicine. And that's it. Thank you.
Thank you very much, Dr. Calvert. So there it is, our initiative, our outreach, the link. So if organizations or sporting organizations, we're encouraging you to make the link with us and utilize our facilities as much as possible. So we're moving on, and we're doing well with our timing. So we're now moving into the second full presentation, which is going to be done by Dr. Rhonda Hudson. And Dr. Hudson is a native of Georgetown, Guyana, although she's been living in Jamaica for quite a long time. So we want to call her Jamaican, although she mightn't agree. Past student of Holy Childhood High School, she received the Bachelor of Surgery and Medicine degrees from University of the West Indies in 1996, and later the Master of Science in 2001. And this is followed by the Doctor of Medicine degree in Emergency Medicine in 2002. In 2009, she received a Master of Science in Sports Medicine. So she is a qualified sports medicine practitioner. And she's also certified as a sexual abuse examiner and an examiner trainer. She's currently employed as a consultant emergency physician at the University Hospital of the West Indies and associate lecturer at the University of the West Indies in Jamaica. She has been a team physician to Jamaican athletes for both local and international games. And some of these games are the Central and American Games, which was held in Puerto Rico, 2010. Maya Guys, I think, 2015. Sorry?
Mayaguez.
Mayaguez. Pan American Games in Guadalajara, Mexico, 2011. She also attended games in Toronto, 2015, and Lima, Peru, 2019. And Commonwealth Games in Glasgow in 2014. So here is an individual who has traveled a lot with teams and has quite a bit of experience in the area of sports medicine. Today, she is going to be talking to us about the periodic health evaluation, PHE. And if it reminds me, I think if memory serves me right, this is what we previously used to call the pre-participation evaluation. So we're going to be looking at, again, we're looking at assessing our athletes, not in that cellular level as which Mr. Miller taught us, but we are also assessing their physical medical performance or their medical issues and looking at what we can help with. So I'm going to turn you over now to Dr. Hudson, who's going to be talking about screening our athletes.
Thank you so much, Joan, and thank you very much, Fabian, for that wonderful presentation, and to Rochelle for giving us that link. So please forgive me if I sound a little slowed up. I'm both jet and sleep lagged, having traveled all day. All right, so pretty much the objective here for me is simple, just to provide a brief overview of screening in sports. And there's a fundamental premise that really all persons should be encouraged to participate in physical activity and exercise. And you heard Fabian define an athlete. And we define an athlete a little bit differently. So an athlete is one who engages in regular exercise or training for sport or general physical fitness, typically with a goal of improving performance. So you can understand an athlete is not just someone who competes, but that recreational person who is just trying to keep fit is also considered an athlete. And the idea, of course, is that to make that person ready for sports or to make that person gain that improvement, you need to have good general musculoskeletal, cardiovascular health. It would be good if they have the appropriate fitness level for what they want to do, and as well as good nutrition. And the aim here is to be safe in that sport participation at whatever level that you do. Hopefully to prevent the injuries. Now we know that injuries abound in all aspects of sports. And this is pretty much a census that was published. And football, and this is American football, we're perhaps not surprised, has a high incidence of sports here. But interestingly, look here at this part, that's this green part. This is free time. Free time tops is one of the 4 top causes of injuries and equals the injuries of basketball, of course, in this particular study. And if we look at where athletes injure themselves, the knee, hip, ankle, shoulder, and the neck, commonest sites that the athletes will injure. And of course, nobody wants really to have a vital injury which would lead to permanent neurological damage. A study done by our own Dr. Calvert, right, pretty much looked at injuries, and it indicated here that yes, there are injuries, but a high percentage of injuries in this particular study of hamstring injuries occurred in the 17 to 21 year group, and track and field was the culprit sport in terms of in these particular types of injuries. There are many factors, many risk factors that have been identified in numerous studies, and they have been grouped into intrinsic and extrinsic, as you see here. And pay attention to, of course, health, previous injury, and things like joint instability, your particular anatomy, and that has to do clearly intrinsic, how you're made up, your skill level. Psychological factors can affect your risk factor, affect your risk of having injury. And then there are things that have nothing necessarily to do with the person, but these are the extrinsic factors like coaching rules, protective equipment, and perhaps not surprisingly, if you look at non-organized sports, it has a higher risk of injury than organized sports. And pretty much this says, well, we do know that if you've had a prior injury, then you're more likely to be injured in future sports. And this was a particularly interesting finding, that if the athlete was concerned about getting injured, he or she had a 2 times greater risk of actually being injured compared to the athlete who was not particularly concerned. So we know there are a number of factors that can affect the risk of sports. And if we compare team and individuals, it has been shown that team, and again, perhaps not surprisingly, team sports have a higher rate of injuries. Individual sports tend to be a little bit more protective comparatively. And one of the things that it may be that the other thing you look at is that individuals tend to have higher intensity sports, right? But teams tend to have more competitions. And the idea, the more competitions you have, the more risk you have of having injury. And this is something that I think we need to be very careful of and pay attention to, especially as coaches, parents, sports medicine physicians, and sports medicine personnel. When you have a young athlete who begins to specialize in sports, the risk of injury is higher. And this was borne out in another study. And it says here, females particularly, as the younger you are, with a high degree of specialization, the risk of injury was higher compared to their male counterparts. As well as if you have your training hours exceeded your stated age for the week, and if your training hours were greater than twice your play time, then these things increase the risk of injury. Our own Dr. Singh and Mansingh did a study, and they found that the playing surface and the landing technique, or the poor landing technique, were actually associated with an increased risk of injuries in our netballers. So the idea then is that, could we screen, could we do something to try to determine whether it's intrinsic or not, what that athlete may have that predisposes him or her to injury? And there's a lot of debate about this whole screening. And if you look at this, I've just put it here, that scores, when you do all these various tests and screens, that the scores are similar in injured and uninjured athletes. And that kind of confounded the issue. But further, that the risk of injury is not synonymous with having the injury. So what do we then do when we identify the risk? Do we prevent participation? Redirect to a less riskier sport? Is there a role for rehab prevention programs, regardless of whether or not you screen the athlete? And whether, and this is where a lot of talk is, you should have general sport-specific prevention programs for all athletes, regardless of whether or not they have been screened, and regardless of whether or not you have identified risk factors. In other words, the better approach would seem to be just have prevention programs for everybody, and life should be good. So the idea is that, where are we heading with our prevention programs? So let's look a little bit at where it all began in terms of this screening. So in 1973, Japan started this particular program targeting very young persons using a questionnaire, ECG, and examination. And they reported that they had an overall reduction in death among these athletes. But interestingly, if you look at the amount of athletes who were screened, only 9 of them out of over 35,000 were found to have cardiovascular disease and restricted for activity. And it's studies like these that tend to say, well, why are we screening anyway? Is it cost effective and so on? Then Italy, most of us know and understand Italy, I think, sort of really took this. And they legally mandated screening in their athletes beginning in 1982. And they would actually restrict the athlete from participating in sports or redirect them. And they were able to show that their program reduced death from sudden cardiac death. in the screening period. Israel took it on. They too had mandatory screening, but they took it one tad further. They in not just a history and examination and an ECG, but they had a stress test. Of course, the results were not, when they compared the overall results, they were not exactly suggestive that it really did make that much of a difference, although there was some criticism of their methodology. And the early screening methods looked particularly at decreasing the risk of sudden cardiac death. And pretty much the problem is that sometimes, because it is sudden, it was often the first manifestation that that athlete had a cardiovascular problem. Who wants to know that when they have died? Is a leading cause of death in athletes. And therefore, it is reasonable then to presume that you want to do screening in these patients to see if you could identify those at risk and could you do something for it. And what we do know is that sudden cardiac death is about 4 times more likely in competitive athletes than non-athletes. And depending on the country and the study, the rates, the incidence varies from as high as 1 in 9,000 person years to as low as 1 in 160,000. Of course, is coming out of the US and you know, well, I reserve my opinion, but the US is one of those persons who have a great deal of issues with how persons should be screened cardiovascularly. What do we find, or what have they found when they screen? Well, lots of things. Everyone knows hypertrophic cardiomyopathy. They can find coronary artery disease, all sorts of things that they can get themselves into. And these things can lead to death. In Trinidad, pretty much a report, it's an old report, but 6 cases, really 5 that was related to cardiovascular issues. Of course, 4 of them had a congenital heart anomaly that was either not detected before or was not particularly taken into consideration. Perhaps they had no screening and therefore it was not considered in these patients. And it is quite unfortunate, of course. So who is at risk of sudden cardiac death in sports? Pretty much we said athletes, and if you're competing, those who are doing vigorous exercise, especially if they weren't doing any exercise in the first place. Older persons, of course, because there's an increased risk of atherosclerosis and therefore the increased risk of myocardial infarction. But this was an interesting finding that in France, they looked at a 5-year period, and pretty much right across the board, they found that 90% of their sudden cardiac death occurred during recreational sports. So it's important that when we're talking about screening athletes, we use a broad term for athletes and not just those who are competing for a country or a club. So let's talk about the screening when PPE had nothing to do with COVID-19. So this was generally, or has been generally, the recommendation. It's that what it is, it's really medically evaluating large numbers of persons before they actually participate in sports, right? Of course, identify risk factors and perhaps do something about them. The American Medical Association went a little step further and said this screening was to identify a risk for injury or sudden death and to disqualify them from participation or ensure they receive adequate medical treatment before participation. As well as though to say that this screening should not be just to disqualify them unless there was a compelling reason. Clearly, what you want to do is to reduce the risk of death. So if you find overt disease correct, in asymptomatic persons, detect a risk factor, risk stratify them, perhaps put in a prevention program, treat them, of course. Then the problem comes in whether there's participation versus prohibition from the sport. And that's going to vary depending on where you are. And most persons think of PPE or pre-participation evaluation. A lot of it is centered on cardiovascular screening because, of course, the endpoint of death is high. The problem, the controversy has to do with putting what exactly should this PPE consist of. Most persons agree it should be a history, it should be an examination, but there's a lot of controversy. Should the athlete get a routine ECG or electrocardiogram, citing costs, that it is expensive, that there is a low incidence of sudden cardiac death. It is low among athletes. You do have false negatives, you have false positives, and then if you're going to use all of these things to tell an athlete they should not participate when they have a big contract waiting, are you setting up yourself for liability? Who exactly is going to take that on? A big problem, of course, is a lack of qualified physicians to interpret ECG and make decisions. And there are few studies out there that say, look, it does not necessarily make a difference on mortality, even when you include an ECG as part of that screening. And this was the Israel study I was telling you about, that before they put in this mandatory screening and after, there was no difference in death. The idea then, why are we doing it? Now, we do know, again, the ECG has come up with some scrutiny. But what if you look here carefully, you'll see that really, if you compare ECG, history, and physical examination, that the ECG actually has a low false positive rate compared to the history, right? And it has a low false positive rate in general, all your studies put together, compared to both your history and your physical examination. It has highest sensitivity of the other two, right? And that's important because as a screen, you want something with a high sensitivity. Then a lot of it has to do with your methods you're going to use, your interpretation standard. And these are the three that have been studied, the Stanford, this one, and the Seattle. And the Seattle one has sort of won out in terms of its accuracy, its low false positive and low false negative rates, okay? So this is the Seattle one really is the one that is being touted in terms of ECG interpretation. Now, of course, it looks like this, and we're not going to go through that. But the point is, it is not simply about doing an ECG and saying, okay, it looks grossly normal. We have to scrutinize that ECG very, very carefully, and we have to ensure that the right person with the best skill is doing this thing. Now, what this shows is that on their own, various skill of physicians had varying degrees of accuracy interpreting an ECG. But when you add the screening tool, that increases significantly. So the idea is, even when you look at a cardiologist, the idea is not just that you want to have a cardiologist do this thing, but they need to do it in conjunction with these screening tools, because we know the athlete, him or herself, have some changes that you don't want to misinterpret as abnormal. So essentially, the American Heart Association, they have a 14-point screening guidelines, and they recommend that it is used as part of the screening program. But they say that an ECG may be done, right? Under certain circumstances. So you do the history, do the examination, but you may do the ECG. It is not mandatory for you to do so. Now, if you look at some of the things that have been detected on screening, a few of these things here cannot be picked up. Wolff-Parkinson-White syndrome, long QT syndrome, for example. You may not be able to pick this up at all with just a history and an examination. But these are all associated with sudden cardiac death because they produce arrhythmias, which can be life-threatening. Okay, so there is indeed a lot of favor, a lot of backative, if you will, to have an ECG as part of your screening armamentarium. The idea then, though, one of the things people look at screening, should we be screening? They say the final step is to document at an intervention program targeting those athletes who have a high risk, and then putting an intervention and see whether or not it works. And we are still lacking in that area. And therefore, I put it to you that perhaps another 5 years, we may be revisiting this whole thing of PPE. So the recommendation, pretty much most persons still recommend you should have as part of your evaluation a targeted personal history, family history, physical examination, and the recommendation is indeed for a 12-lead electrocardiography to be done. The question is, how often? Now, these are the ECGs of a young man. In the first instance, the top one, and I don't want you to go through, that's fine, take my word, the top one, it's normal. He is reviewed as part of screening, and it is an absolutely different ECG. This is abnormal, and this increases his risk of sudden cardiac death tremendously. So are you not doing this thing on a regular basis, then you would have a problem. And we see this if you compare sort of pre and the first one and an initial one, the detection rate of things increases. So the point here is that the pre-participation evaluation really and truly should not necessarily be called a pre-participation evaluation. And the objectives of the screening have changed a little bit from trying not just to detect cardiovascular risk factors, but also other things here. And this is where the biggest strength, and those persons who are in favor of doing screening of athletes say, look, it's not just about screening for something that is rare. It can determine your general health. It serves as an entry point to the healthcare system. It provides an opportunity to initiate discussion on health-related topics. So the whole shift has been not pre-participation examination, but periodic health evaluation. And it is where we're left with. Meaning, I do it today before you start. I should have a program that says I'm doing it regularly. And perhaps that regularly could be once a year. Of course, you have to take into a lot of consideration the cost, but it should never be considered that I've done it once and that's it. And we know from our periodic health evaluation, we have general medical problems that come up that require attention, cardiovascular problems, and musculoskeletal problems. You remember we spoke about injury. So it has sort of shifted away from just cardiovascular screening to this whole person screening. And you saw earlier we talk about nutrition, and a lot of the historical questionnaires also include nutrition and other factors and psychological part as part of the general medical screening. So we say then it's not all about the heart, and lots of persons have developed various tools to test your musculoskeletal readiness as much as they test your cardiovascular readiness. And this will differ, of course, from sport to sport. And just to put in a plug, we did our own periodic health evaluation for those of you who did not know. And we adopted the approach that we would have a history, we would have a physical examination, we would have a musculoskeletal examination, and we did, of course, include an electrocardiogram for our patients. And I just want to end here with this little testimony.
All right, yes, thanks for having me. This is Coach Smythe from Muket High School, and we do appreciate the Jamaica Association of Sports Medicine for accommodating us, having us. This is such a welcome sight, you guys coming here in Western Jamaica, Montego Bay Community College, and assessing these kids. You know, this is well needed. We need more of this. We support this. I give this a thumbs up.
Good. So he said we need more, and of course we intend to do more. So we say that pretty much in summary, that pre-participation evaluation indeed is recommended, but it should not be a one and done. What we prefer is a periodic health evaluation that occurs perhaps annually, could be more depending on if something is identified. ECG, or certainly I'm positioning that ECG should indeed be a part of the screen, because not all things are actually picked up by history and examination. And it is, of course, more than assessing cardiovascular risk. Thank you very much, ladies and gentlemen, for your time and attention.
Thank you very much, Dr. Rhonda Hudson. Very informative. Yes, it's great to remember that we do need to have a full health evaluation and not just the ECG, and that there are many of us out there who are not athletes as defined by Mr. Miller, but we are recreational. And as we have seen from Dr. Hudson's, recreational activities seem to cause a lot of problems, run us more into risks of injury than if it is a structured, organized training program. So yes, the need for the periodic health evaluation. Now I see Mr. Alvaranga's hand is up for questioning, so we will take a few questions. I am going to ask him please to unmute. And if it's a question, you could go ahead for me, please, Mr. Alvarado.
Good evening to you all. Good evening, everyone. I had my hand up from Dr. Calvert's presentation. She mentioned sports medicine persons assigned to different disciplines, different associations. Who is the person assigned to the swimming federation? And how can local clubs access the services of the Sports Medicine Association? I know Diallo, Dr. Brown, we work extensively along with Jody, Dr. Simpson and Dr. Olivia Rose. But in your presentation, you spoke about sports medicine person assigned to the different federations. Who is Dr. Calvert, who is the person assigned to the swimming? And for Dr. Hudson, your early slide, you mentioned team sports, while swimming is an individual sport with a high level of injury due to the excessive overhead use. We do have a lot, and can some greater research be done looking into swimming? As I will develop post Ali Atkinson athletes for world records and beyond, and I would like to know where the research can guide me. Over.
All right, Mr. Alvarango, with regards to your first question, right, so the link is the link as an initiative is just being established. So we're putting the information out there. We have yet to collate all the information from all sporting organizations, but you can be assured that your organization will be on top of the list since you're indicating that interest now, and someone from the medical liaison committee will make that contact with you. So Dr. Pierre Brissett is one such person. Dr. Rhonda Hudson is another on the committee. So we will make that communication with you. Thank you.
Dr. Calvert, if I could just say, Mr. Alvaranga, I do believe swimming was contacted. I think I remember Dr. Pierre Brissett saying that emails were sent out, and maybe the secretary can back me up.
Yes, right. Yes. Okay. So the link, Mr. Alvaranga, is an initiative. It is not that we will assign persons, or we have sat down and assigned persons. It's an invitation that is sent out, and sporting bodies will indicate a willingness to do that. And to date, I think we've had only about 3 responses, and it would appear that the interest is not there as yet. So it is in its infancy, but it's not that we sit and assign persons. Our persons would have to agree and volunteer their services to this link as the interest is shown, right?
All right, thank you. Can local clubs access these services? And the reason I ask you, I did mention Dr. Jody and Simpson. We work with her, Dr. Diallo Brown, Dr. Jason Scotty, big up, Olivia Rose. I endorse the full gamut of sports medicine, Dr. Christine Frey Aiken. But I want to be more. I want to, get more out of it for my athletes, and I work with a lot of juniors. David is a senior coach. I gather a lot of persons here because in 2015, after meeting Jody Simpson, we did pre-participation screening. Sadly, one of my swimmers was 12. After doing the pre-participation screening, she was not cleared for swimming. Her mother was a doctor. She was numb. They did the heart surgery and she's competing now. One of my parents, who I encourage all my parents to do the screening nonetheless, she was a netball player and she ended up becoming the manager because she had a heart condition. So I fully endorse this, but with the Jamaica Association of Sports Medicine, I want anything that I'm missing to come in there, and can local clubs outside of the federation, if they're not responding to the call, access these services?
Yes, we have not restricted it. Of course, you would want to ensure that your elite athletes have access, but no, we have not said we would restrict it. And indeed, if you have clubs, because you want when they're starting out to have the right framework and be guided in the right way. So yes, it's not restricted to them. And with respect to the other question you asked about studies, I'm sure there are lots of studies out there. Now, the issue wasn't saying that each sport will have its own set of injuries that are specific to it, and we know that. But that particular study I showed just looked at the comparative risk of injuries. In other words, if you compare team sports and individual sports, there's a higher risk of injury with team sports. And a lot of it has to do with the fact that they do more competitions than persons who are individuals. But the studies are out there, yes.
Thank you very much. Yes, sadly, I'm a swim coach. Swimming is both an individual and a team sport. But yeah, for Dr. Hudson, we do the pre-participation screening. Diallo, I'm going to put you on the spot. Great. Because Diallo travels with swim team to Central America and Caribbean Games, to the Olympic Games. And, once we do our screening, we find stuff with Jody, who with the functional movement screening Jody and Simpson, we go over to Dr. Diallo Brown. He does the strength work, the correction. But I look at a lot of these presentations. I'm always here. And I see studies on track and field, netball and stuff. And with Alia Atkinson being the woman of color, world record holder, we want some research on swimming so that I can buy into them, tap into them and create post Alia Atkinson world record holders.
All right. So you've just given us the idea for our next Keeping Pace seminar, right? We're going to have one on swimming. That sounds like a plan, sir?
Sounds like a plan. And
sounds like a plan.
Central Branch should be doing the next Keeping Pace, which is Dr. Jody Simpson. So yes, that's an excellent idea.
Sounds like a plan.
If you need Alia, I could make contact and get her in there. Really? And thank you. I've learned a lot. I mean, the last two, Scotty, the psychological, looking at the body language. I'm always here. We'll always be here, seeking to raise the bar in swimming.
Thank you, sir.
Thank you very much. I think there weren't any other questions, so we can move
Sorry,
on.
There's a comment.
There's a comment.
Right, by Dr. Hamilton.
That you could probably read.
Where, Okay, so we have here from Dr. Scott Hamilton, the Jamaica Psychiatric and Jamaica Psychological Association will be interested in this link and assisting, and through the psychological first aid we could ask athletes if there is any history of cardiac issues in their families, as this data would be valuable to the medical personnel. So that's a note in the chat.
And just to say that,
Dr. Scott Hamilton.
yes, sorry, just on that issue, that
sorry, Rhonda, we lost you.
Is the intake about family history and cardiovascular. Oh dear.
We're losing you, Rhonda. You're breaking up.
Sorry. Am I still with you or?
Yes, we're good.
Yes,
Go ahead.
Okay, great. I was just saying that that question about a history of cardiac injury issues in the family is already part of the screening questions that we ask. So we're well on our way, and I thank you for that, Dr. Scott Hamilton, and we will certainly make a note of it. Thank you so much.
All right, so we're going on now. We're next going to have Mr. Paul Russell of Abbott Nutrition. Abbott has been very good to sports medicine. They're always here contributing, helping us financially, sponsoring our activities. And we're really appreciative of their continued support for our ventures. And they say, he always says he's always be here. He'll always be willing to come and talk about the products, the nutrition products that Abbott has available, not only for our athletes, but other individuals who need that additional little nourishment to keep them going. So I'm going to invite Mr. Russell to come forward. I also would like to let you know that this presentation by Abbott comes with a little surprise gifts. We have some gifts. There will be a couple of questions, well, couple in Jamaican terms is 3. Questions at the end of the event, and we will, I believe there is no one on the YouTube. I looked before and I didn't see anybody.
We have at least 2 persons. I'm not sure if there's more.
We have 2 persons on
there were
YouTube.
At least 2 I saw.
All right, so we will definitely want the answers to the questions to be put in the chat box, and we are going to monitor that very carefully to see who answers. So again, over to you, Mr. Russell. Go ahead for me, please.
All right, thank you very much. Let me just share my screen. All right, can you see my Abbott A?
Yes.
Yes.
Okay.
Abbott A is there.
All right, great. Good afternoon, everybody. My name is Paul Russell, as was mentioned before, and I just want to thank the Jamaica Association of Sports Medicine for the opportunity to present to the participants here at the Keeping Pace seminar. Now, Abbott, you hearing me good? You can hear me okay?
Yes.
All right, so
Yes.
Okay. All right, so Abbott produces and markets several products across the various stages of life, from infants going straight through to the aging, and we also take into consideration persons with special health needs. So firstly, we're going to be looking on the Ensure line of products, and there are 6, and I emphasize 6, 6 different types of Ensures that are available in the market. We have the Ensure Original, which provides complete balanced nutrition for everyday health. We have Ensure Plus, to help gain and maintain a healthy weight. We have Ensure Complete, which provides 30 grams of protein, complete balanced nutrition. We have Ensure High Protein, which is targeting nutrition to stay active and strong with 16 grams of protein. We have Max Protein, which gives 30 grams of protein and 1 gram of sugar for people with elevated protein needs. And we have our Ensure plant-based protein shake, which is dairy-free nutrition with 20 grams of plant-based protein. So let me just quickly highlight Ensure Complete, which provides complete and balanced nutrition. In this presentation, you're getting excellent source of high quality protein. You're getting 30 grams of protein per serving. It has the highest levels of calcium and vitamin D for bone health of all our Ensures. It has 450 milligrams per serving of plant-based omega-3 fatty acids for your heart health. And it has antioxidants, vitamin C, E, and selenium for immune health. It contains fiber, 4 grams of fiber per serving to support digestive health. And it's calorically dense in that it has 350 calories per 10 fluid ounces. It's suitable for lactose intolerance, and it comes in assorted flavors, vanilla, milk chocolate, and strawberry. My next product that I'm highlighting is new on the market for 2022, and it's Ensure plant-based shake, protein shake. It's 20 grams of plant-based protein. It's 180 calories with 5 grams of fiber. It's soy-free, it's dairy-free, it's non-GMO produced, and for your vegan athletes or patients, they can benefit from a presentation like this. While I have you here, let's talk about your diabetic patient or your diabetic athlete. We have Glucerna Hunger Smart, which is has a blend of slow-release carbohydrates to help minimize blood sugar spikes. You have 15 grams of protein to manage hunger and 4 to 6 grams of fiber. It has antioxidants, vitamin C, E, and selenium. It's only 180 calories in 10 fluid ounces, and it comes in assorted flavors, and is suitable for lactose intolerance. And my last product that I'm highlighting is Juven for optimal wound healing. It's a therapeutic nutrition powder that is mixed with 8 to 10 ounces of room temperature water or juice. And it contains arginine, glutamine, HMB, which is a metabolite of leucine, hydrolyzed collagen, vitamin C, E, B12, and zinc. And it's clinically shown to support wound healing in as little as 2 weeks. It's recommended 2 packets of Juven per day to start to see healing. And I've included my business card with my cell number, 489-6093, and my email address, which is paul.russell, spelled with 1 L, @abbott.com. It's spelled with 1 L because we have 2 Paul Anthony Russells in the organization. So unfortunately, to Abbott, my name is spelled with 1 L. Feel free to touch base with me. We can talk about the products, and I'll also put my telephone number in the chat so that you can contact me at a later point. Thanks again for allowing me to speak. Let me just say that I can be found at CarMed at Lady Musgrave Road in New Kingston. Thanks again.
Well, thank you. Short and to the point. Are there any questions for Mr. Russell? Or anything about any of the products that anybody wants more information on before we get into the little?
Just to say, I've recommended his product to one of my patients, and she's doing well.
Awesome. Great to hear. Those are the anecdotes we love to hear from time to time.
Mr. Russell.
Yes.
I would like some more information on the product that is for the diabetic athletes. In my study, I found that few athletes are pre-diabetic actually, very close, and these are top performing people, and it's very shocking.
Yeah.
So I will definitely call it to see how we can arrange something.
Yeah, man. We have quite a few persons who have reached out to us who are diabetics, and they're actually competing. And along with their clinician, they've been using our product. So yes, I can point you in that direction and give you some info as best as possible.
All right, thank you, sir.
All right.
Sorry, Mr. Russell, I have a question.
Yes.
My question
Yes.
comment. So the comment first. I like the max protein. I tend to drink that. The chocolate is the best flavor. I just say that. Not bad. But I don't think that one is good. But I had a question. I was wondering whether the Ensure products still contain the HMB. I noticed that the Juven does. Like, can you say more about the HMB? I know back in the day, it was very popular among the bodybuilders, sports supplements. I don't hear much about it nowadays. So is it still a thing?
What has happened is that the studies are now showing that if you have the precursors to HMB or the amino acids that make the HMB present in adequate quantities, then the body itself will make the HMB, as opposed to putting in HMB as part of the components. So what you find is that leucine is leucine from which HMB is made is very prominent in all our presentations. And so instead of putting in HMB, now we make sure that we stress that all our products have high quality proteins, and there's a leaning towards adding leucine and making sure leucine is present.
Okay.
So the body will make HMB once it has leucine in the presentation.
Okay. Because I noticed I don't hear HMB spoken about much among the bodybuilding people. I don't see the magazines and stuff. So that's interesting.
The key is high quality protein, and that's what a lot of persons can't make claims to. So we follow the studies, we look and see what's going on, and if the body can make it, then all the better.
Right. So the Juven, would you say, you mentioned it's for wounds, but would you say it's good for muscle strains, injuries like that?
Any sort of difficult muscular issue, Juven can be applied internally, externally.
Okay.
Yeah, and there are ongoing studies with it, but I mean, if you go on juven.com, you'll see all the studies that have been done, and very impressive results in terms of wound healing. And it's primarily the combination of just amino acids and hydrolyzed collagen, and just in that proportion, you get excellent results.
Okay, that's something to look into for sure.
Right, yeah, man. All right, take care.
Great. Thank you very, 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 very much, Mr. Russell. And again, thanks to Abbott for being there with us, always being a part, a group that we can turn to for support. Thank you very much, Abbott Nutrition. So now, the first question, we have 3 questions, and we're going to save 1 question for our YouTube persons because we may not be able to monitor them as quickly as we can from the Zoom link that we have here. So the first question, and you are to type the answer in the chat. Let me repeat. Type the answer to the question in the chat. So here is the question. How many Ensure products are on the Jamaican market? Send your answer now. Oh my, it's coming in fast and furious.
I saw Mr. Royal Allen. He was like over the keyboard waiting.
I think his hand must have been just on the keyboard. I couldn't get it out of my mouth fast enough.
The response came fast and hard.
Okay, so first winner is Royal Allen. I'm sorry. I needed to have the basket here to show you, but it's a different room. But anyway, I will show you in a.
If you need help with the basket.
You mean what? The products in the basket?
Yes.
I don't think he's going to give you any, Let me tell you, when I saw the baskets, I said to myself, boy, I wonder if I can get one. Okay, here it is. No, again, your answer is to go in the chat box. Next question. How much protein is in Glucerna Hunger Smart? Type your answer.
What's the correct answer? I'm seeing Johnny Crickets with 20, Rochelle Carver with 15, Was the first answer I'm seeing. I'm seeing 2050. What's the correct answer? Joan?
The answer to the question is 15 grams. So Dr. Rochelle Calvert, first person to put that up.
Yes.
So there we go, second one. Now we're going into our YouTubers.
So of course they might have slight delay, but I'll watch on YouTube.
You're watching? All right,
Yeah.
so please, this is for the persons in the YouTube section.
8 persons there now.
All right, what Abbott product is used for wound healing?
Type in the YouTube chat.
Type in your YouTube chat the answer.
Because there's a delay on the YouTube, so not seeing any responses yet. I think if we wait too long, then we'll put it back into the Zoom. No responses yet. Joe, I think you're on mute.
Tajay Grant.
Oh, yes.
Has,
yes, Tajay has,
okay.
Yeah,
Tajay Grant had Juvena, which is
there's no such thing as Juvena. I don't know what
actually wrong. And the other person, there was somebody right behind them. What was that? It disappeared from my.
It disappeared, yes. Is that sabotage? I don't know.
Aaron Oti.
Yes, Aaron Oti has typed Juven. Right. I'm seeing Aaron Oti has the correct Juven now. Hello?
Aaron Oti.
Yes, he put Juven first. So Mr. Ross, I don't know if you want to have mercy on Mr. Tajay Grant. I don't know if it's a typo. Where you said Juvena.
It's out of my hands.
Okay.
It's out of my hands. It's completely in your hands. You have the answers, so you monitor your people.
Well, the only thing I can say is that they're near to each other, right? They both
well, one has an A on it, and so it's a call by the association.
Well, if we were in school challenge, they would not accept it. So we are going to go with Aaron Oti. So we have Dr. Calvert. So first answer is Ron Allen, Dr. Calvert, and Aaron Oti are our winners. Now, the baskets are in Kingston with me. For those persons who are outside of Kingston. I'm not sure. We can discuss after how the collection of these baskets, and they're lovely. I will, if Dr. Diallo will take over, I will run and get the basket so that I can show you what the basket looks like.
I thought you were gonna say if I would take them home. Okay.
No, you're not you and the people them for this side.
All right, thanks for having me.
Thank you.
Yeah, I'll put my information in the chat and my telephone and email address again, so persons can contact me should they want to ask any further questions.
Right. Okay.
All right, take care.
Thank you very much. I'm handing over to Dr. Diallo. All yours.
All right. So good afternoon again, folks. Thank you for staying with us thus far. So at this point, we're going to go into our panel discussion. So as myself, I'll be one of the moderators for the panel discussion, along with Dr. Rochelle Calvert, our next moderator. We have 5 panelists. I think they're all available, hopefully. So we'll do just a brief introduction of each panel, each panelist. So I'll go ahead and start. So first 2 panelists are, but you heard from them already, Mr. Fabian Miller and Dr. Rhonda Hudson. I won't totally reintroduce them. Mr. Miller is, of course, a researcher, senior lecturer, researcher in biotechnology, all sorts of stuff. Many hats he wears, as he always says. He wears many hats. And of course, he's our co-chair for the education committee. And as you mentioned, he's also involved in the research with JASM. So Coach Avaranga, that's another thing. We can look at that whole research thing again. So there's that. Dr. Rhonda Hudson is, of course, or the president of the JSM. She's a sports physician and an emergency physician. And I think you wear a few hats as well, right, Rhonda? All right, so there is that. I'll then also introduce another panelist, Dr. Kevin Jones. Dr. Kevin Gwynn L. Jones. There we go. All right. So Dr. Jones, he is a consultant orthopedic surgeon at the Mandeville Regional Hospital. Let me put a plug right here. He's also our immediate former president or immediate past president of the JSM. He was trained, he did orthopedic residency, the orthopedic residency program at the UWI Mona campus. And he's a member of a number of professional organizations. So the Jamaica Orthopedic Association, the JSM, of course, the AAOS, American Academy of Orthopedic Surgeons, as an international member. He's a fellow of the Royal College of Surgeons, that's based in Edinburgh. I guess that's for orthopedics, right? He's also the chairman of JALCO's Therapeutic Use Exemption Committee. So I'm sure you're listening to Mr. Miller's presentation with keen interest. And he's also a member of the Jamaica Track and Field Coaches Association. And Doc, you also have something with GA3, is correct? I think you might have something there too. So his research interests. Say
no, I don't have any with J-Trace official. I don't work with, but nothing official J-Trace.
Okay, gotcha. Beg your pardon. All right. So Dr. Jones' research interests include tibial plateau fractures, this is straight orthopedics, huh? Tibial plateau fractures, blood loss associated with isolated femoral shaft fractures, that sounds like a mouthful, and repetitive use injuries in athletes. So what's an interesting contrast is that Dr. Jones is also a field events coach, was a coach from Monroe College from 1988 to 2014. And I'll just add here is also a former, or should I say retired, athlete in field events and also volleyball. So, and that's actually a part of the reason that he's actually here as a panelist. So looking forward to hearing from Dr. Jones. All right, Dr. Calvert, right again.
All right, so I'll now introduce Dr. Ramon Hunter. Dr. Hunter is a graduate of the University of the West Indies, where he attained a BSc in physical therapy, and he's also a recent graduate in the MSc Sports Medicine program. He also pursued doctoral postgraduate studies at the Nova Southeastern University in Florida, where he attained his doctoral degree in physical therapy. He spent 8 years working at the University Hospital of the West Indies in the Department of Physiotherapy before being employed as head and senior sports physiotherapist at the University of the West Indies Sports Medicine Clinic. He is also an adjunct lecturer in the Faculty of Sports and serves as the chair of the medical committee of the National Powerlifting Association of Jamaica. Dr. Hunter is passionate about teaching physiotherapy, and he's passionate about teaching physiotherapy and exercise science, which he believes is part of what God has called him to do. In his spare time, he enjoys attending and serving in church, teaching, reading, and working out at the gym. And we also have the privilege of having Mr. David Riley in our presence. So Mr. Riley is the founder and performance coach at Technique Lab Sports Performance and Fitness Center in Kingston, Jamaica. He's a IAAF Level 5 Sprint and Hurdles Track and Field coach who holds a Bachelor of Science degree in Mechanical Engineering from Northeastern University and a Master of Science degree in Material Science and Engineering from Georgia Institute of Technology. An engineer by training, he has studied both the mechanics and biomechanics that has helped him over the years to prepare his athletes at Wolmer's Boys School to their historic win in the 2010 ISA Boys and Girls Championships. And he's also head coach at Excelsior High. He is a technical director of track and field at both Excelsior High School and Excelsior Community College, where he's leading a team of coaches to rebuild the track and field program there. His recent project, Technique Lab Limited, has served athletes from 10 different countries across some 9 sporting disciplines to date. He is a national senior track and field coach for teams to the IAAF World Championships London in 2017 and Doha in 2019, as well as Pan Am and CAC Games. And he has also served as head coach to the Character Games, Youth Olympics, and the World University Games. He has conducted seminars and training camps across the Caribbean and Japan. He's also a television and radio track and field analyst covering the World Championship and the Olympic Games. Coach Riley, as he is often called, is also the president of the Jamaica Track and Field Coaches Association and serves on the executive of the Intercollegiate Association from 2016 to present. These are our panelists.
Sorry, I was on mute. Yes, all right. Thank you very much, Dr. Calvert. So without any further ado, we will right into it. So basically, Dr. Calvert and I will take turns. So I'll start. Okay, so this is a bit of a, well, almost like a roundtable question. So Dr. Hudson, Dr. Jones, and Dr. Hunter, you guys first. As well, for each of you, as a sports medicine clinician, what does sports science mean to you? And what do you see as the general role of sports science in your practice of sports medicine? So I'll start with you three first. Since Dr. Hudson is perhaps the first looking of all of them, Dr. Hudson, you can go first.
Boy, I was just about to volunteer somebody else. All right. I think just like any aspect of medicine and most of our work, science related to sports adds a body of evidence that allows us to be guided rather than it's about what we feel and what we think and what has been passed on to us from coach to coach or doctor to doctor. So it's really allowing, and if it's done properly, for us to get a properly studied aspect of sports that is applied to improve the way we do things and ultimately improve the outcome. So science is important because it takes away that subjectivity and it takes away that I do it, this is my way, rather than if we rely on the science to guide us, we can say this is the way that it helps. This is the way that has been shown to help, and this perhaps is best practice. So it allows that. That would be my sort of nutshell kind of take on science and sports. Thank you.
All right. And how would you say that it plays a role in your practice of sports medicine as a clinician?
Well, science on a whole plays a role in my practice of medicine, period. We don't do anything with, well, very little do we do without looking at the science. Science guides how we treat injuries. Science guides how we treat medical conditions. So it does play. And I think if we even think of what we just spoke about, the periodic health evaluation is a science that looked at that. Right. That says, look, you know, this is something we should be doing, and we've been advocating for it for years. But it's not a feeling. Study after study has shown that it makes a difference, and we can argue about, you know, if you save 9 people out of 40,000, I'm sure to those 9 it makes a big difference. So I think it does make a difference. And we, I think, are embodying that. So we are putting the science to work.
All right, thank you. And Dr. Jones?
Yeah, I never heard a question because I had stepped away to try and reduce the noise level inside my place. But what was it? You kind of remind me the question again?
Yeah, man, no problem. So 2 parts to it. So how do you, as a sports medicine clinician yourself, what does sports science mean to you? And then what do you see as a general role of sports science in your practice of sports medicine? So I guess kind of all the same thing.
Okay, all right. So a lot of what Rhonda said, I concur with. Science forms the foundation of everything in terms of training, in terms of diagnosis and treatment. And for me, it's the basics, the fundamentals for everything. So like for every athlete that comes in who gets injured, I try to find what is the underlying cause of why they got the injuries. And sometimes it's something intrinsic to them, flat feet, knock knees, bow legs, recurvatum in the knees, or something like that that can be fixed or corrected with something scientific. So I look and see what is the underlying problem based on what the guidelines are for the science, especially for like hamstring injuries. You know, I've diagnosed and treated a lot of athletes at various levels, some going on to win at the highest level, who have had hamstring problems with underlying issues that I've actually sent to Dr. Riley, to Coach Riley's technique labs for evaluation. That's all based on the science, you know, because we know the science with hamstring quad imbalancing, tight hamstrings, etc., and how that affects hamstring injuries. So for all athletes who come in for the first time, after evaluating them, I usually send them off to get tested. And several of them, some who have corrected and, like I said, gone on to great things, had significant hamstring quad imbalances, which is based on the science. So it's the foundation for everything that I do, basically. Look at the basics, what the science says, and then try to correct their problem based on what the science recommends. And then you can get to that later on.
Good stuff. Thank you. Thank you, Dr. Jones. And Dr. Hunter, same question to you. Again, what does sports science mean to you as a sports medicine clinician? And how does it factor into your practice of sports medicine?
Hey, good evening, everyone. And thanks for having me.
You're welcome.
Pardon if I sound a bit stuffy, kind of recovering from a little bit of a flu. Took some medication, so I might be drugged up a little bit. With regards to, all right, so in response to that question, sports science plays a very important role. Yes, it's with regards to being led and directed and guided by you know, evidence-based practice, by research, by studies. We also look at with regards to how the athlete or how the person responds, how they adapt to the exercise and how they respond physiologically to the stimuli of exercise, or the stimulus of exercise, right? So that's what it means to me. It means to, and in the context of sport medicine as well, you know, sport medicine being that discipline that really focuses on fitness and also dealing with injury prevention and treatment of sport-related and exercise-related injuries. How I tie that in with regards to sports science, because they both complement each other. In my mind, they both complement each other, because in addition to, yes, so we have an athlete with a sport-related injury, but now we're applying that sports science with regards to, okay, these are some specific exercises that can help rehabilitate, and also not only rehabilitate, but also help to enhance that athlete's performance, depending on a certain criteria like sets and reps and periods and intensity and so on and so forth. So that's what it means to me. You know, in addition to agreeing with what everyone else is saying pertaining to science and evidence-based, but also looking at how each person responds physiologically, the adaptations that they experience while taking them through a structured exercise program.
All right. Excellent response. Thank you, Dr. Hunter. Great stuff, great stuff. So after a great start. And then now Mr. Miller and Coach Riley, I put a similar question to you, somewhat flipped. So as practitioners and researchers in sports science, how do you see sports science fitting in with, or let us say impacting our sports medicine practice?
All right. Thank you again, Dr. Diallo. So as a scientist, as a sports scientist, I mean, everything is about longevity in competition, improving on performance, getting bigger, faster, stronger. You know, science plays an extremely integral role in all of those facets, from creating nutraceuticals such as what Abbott has presented. These are some things that aid in recovery, aid in performance, and science look into these things. Dr. Jones can allude to how some therapeutic chemicals that could be used, they are used in the clinical setting, but also can be used to assist where sport is concerned. With rehabilitation, with healing, a person who just got injured in a match within a day or two is back on the field again, performing, and that is due to the quality in sports science and the linkage with sports medicine. So extremely important. It advances the entire industry on a whole, and again, to preserve fair play, performance, and all of that. It is very important that both stick together and work together. That's how I see it.
Excellent stuff. And Coach Riley.
Yeah, thank you for the opportunity. And this, of course, is a very interesting and important roundtable. The interest in the sports science and the application within the sport tend to be something that the individuals who ask the question, how can I? Those are the persons who access or try to utilize the sports science. Many persons still are not aware of the impact that it can have on the overall performance. And as a result, they don't necessarily employ the sports scientists within their setup. They don't necessarily engage a sports scientist to get a better understanding of how they can actually improve in their performance. You tend to find it mainly from persons who are involved in performance sports and not necessarily in the team sports. Team sports tend to be driven by the requirements of the team, and an individual who is part of a team setup whose individual fitness doesn't necessarily affect the overall outcome of the results of the game tend to be less interested than an individual who is involved in a performance sport versus you on the clock, or you on the tape, you on your lane. Those persons who want to do more, want to get better out of their effort, they're the ones who will more likely to engage a sports scientist. Most times it is after they're injured. So you end up telling them, yeah, you're injured. You confirm that you're injured, but understanding that in fact it should be at the start of the season or the start of your effort to guide you, to help with preventing and optimizing. Those are things that we really have to get the conversation going, so that persons understand the right place in which the sports science and the sports scientists should be fitted as they look to improve their performance.
All right, thank you. Excellent stuff. I like those two words, preventing and optimizing. I love those two words.
All right. Thank you so much for that response, Coach Riley, which kind of helps me to segue into the next question, because you spoke of how it is that performance athletes are the one that generally tend to engage sports scientists, and how exactly sports science will help them to improve performance. So my question to you and Mr. Miller is, what are the ways that sports science or the research in sports science is being integrated into current sports practices and culture in the Jamaican sporting landscape? And the second part of it, do you find that there is support from the local sporting organization, coaches, support staff, and athletes themselves with regards to the use of these newer evidence-based science, sports science technologies and methodologies into current practice?
Okay, thank you, Dr. Calvert, for that question. I've seen where the bigger clubs, the clubs with money, and let's talk about track and field now, who have employed some of these technologies in their preparation and to aid with data collection in order to influence training techniques, which eventually will impact positively on the athlete's performance. I cannot speak to if the government supports, but based on my understanding, we have a culture of where we have to win first before we get any form of support. And we tend to do well with the little resource that we have. And then, hopefully we get some injection. But I have seen where certain clubs invest, a lot of money with certain technologies, and it does pay dividends.
Right. All right, Coach Riley, your input.
All right, so I think locally we are a bit behind with respect to the use of the sports stands. We're all engaged now watching the World Cup, and when you look at the statistics that come out of a World Cup match, the distance traveled by a player during the game, and you look at people traveling 9 kilometers for a game, and you ask the question, what kind of preparation would be required to get a player to that level of fitness that they could compete like that? And that's the kind of information that is collected, and then the sports scientists would help to guide the sports program. We get the success that we're getting in track and field because the individual sport and nature of it forces the individuals to employ these. And again, it comes back to my initial comment that we have to get to the other sports, the football and many of the other bigger sports in track and field, to more employ these things so that we can get the results that we need. Most times people are unaware of what goes into the preparation of the player or the athlete, that their favorite player. They have no clue. They don't know what goes on behind the scenes. And so they see the end product and they think that it's just a mental decision to do that you end up with the result, but it's far from that. We have to really engage the science and employ it, not sometimes, but employ it throughout the entire preparation.
Right. Thank you so much for your response. And I guess most of it goes back to education, presenting the benefits, the advantages of these technologies to these persons and getting them on board, essentially. All right, over to you, Delalo.
Sure. Thank you, Rochelle. So I'm gonna skip down to some individual. I call this section special individual questions. So, Coach Riley, putting you up again. All right. You and I, we had a conversation a few weeks back about some research that you're doing now on some athletes who are currently overseas. I'm just wondering if you'd mind just giving us a synopsis of the research that you're doing thus far, whatever you're comfortable sharing currently. What it is that you're doing now, why did you decide to do that research, and how do you see that research fitting in with sports medicine, or what impact do you see it actually having with sports medicine? Right,
so a lot of things happening, but just a few to give you an idea. When you understand the factors that impact on the overall performance, and you begin to see how within an experiment, which is what training is, to try and maximize those, make the changes to those parameters to get the outcome that you want, you then have an approach to say how you're going to get this done. Within the American system, we find that the athletes that we send to the US on scholarships, the US have quite a bit of rules that prevent the coaches from having certain conversations with their athletes. And one of them in particular has to do with weight. Coaches are not allowed by law to have a conversation with the athlete about their weight, whether they're gaining weight or losing weight or anything like that. But we know that weight, we know that weight is a factor that has an impact on the performance of an athlete. And many of our athletes who go overseas tend to put on a lot of weight initially. Free food, lots of free food, lots of, you go into the cafeteria and it's just unlimited, all you can eat, and many of them, because of their socioeconomic background locally, end up putting on 30 pounds in 1 year. And of course, after that, the performances go down. And this is because we know that weight and especially fat that you might gain, it's not going to help you in terms of overall performance. So what we've been doing, we've been engaging many of the athletes who were on the 2021 and the 2022 World Under-20 team. We have them on this program where they report every Friday, they report their body weight. And we track the body weight. We send them back a chart immediately, and they see where their weight is going. Now, we're not assessing body composition, but body weight, we know is influenced by diet, and we're assuming that people are actively involved in training, rigorous training, and so they should not be necessarily putting on excessive weight that they cannot explain. So an individual will be able to tell you, oh, well, we're doing, these exercises in the gym, so we can assume, okay, fine. Then we know that muscle is more dense than fat. We know that some persons would see a gain in weight, but not weight that is out of control. So we've been tracking this and helping in terms of keeping that conversation. And we're expecting that the athletes for the last 2 years who have gone to the US, who are involved in this volunteer program, to be able to be guided and not lose out in terms of performance because of weight gain, but maybe it might be some other factors, not because they're overweight.
Okay, I'm looking forward to the outcome of some of that research. And just to say quickly, for the panel discussion, so we have a few questions that we're going to go through, but we do plan to open up to general Q&A to the audience, so we can involve them as well, depending on our time. So just putting that out there. All right, Rochelle, your turn.
All right, so my next question is back to Mr. Miller. So Mr. Miller, you would have presented on, the athlete biological passport and how that ties into science and how that can affect, sports medicine and athletic performance. But apart from the use of the athlete biological passport, is there any other aspect of biotechnology that is associated with sports? And, how does this fit into sports science, and how does it affect sports medicine in general?
Okay, thank you for that question. So there are colleagues of mine who are looking at sport from a different vantage point. Again, there are persons who are looking at certain particular nutrient from a certain particular food and how that may impact muscular development and performance. Nutraceuticals. So there are some students who their research is in that capacity, again, to work on rehabilitation and how to improve performance. I've seen that. So far, I believe, my memory serves me correctly, is about 2 other persons who are looking on that aspect. I've seen another research that looking at oxidative stress, regarding to performance. I've also seen research being done on persons predicting when a particular athlete may have injury, looking at certain markers stating that if this elevation continues, then it is likely that person is closer to get injured. So certain studies like that, of course, would impact training decision, when to pull back, when to push certain athlete harder and so forth. So from that level, I've been seeing some work being done. A lot more work to be done. It's a broad field, big field, but so far that's where we are, to my knowledge.
Okay, all right, excellent, sounds good. Diallo, I'm going to turn over to you because I think we do want to get some questions from the audience. So,
all right, seen 2 raise hands already, so no problem. Here. All right, so Dr. Hunter, back to you again. Yes, Dr. Hunter, that's you. Okay, there you go. All right, so Dr. Hunter, you and I talk all the time. You know me very well, and you know what I'm into. So, you know, I can't speak about sports medicine and sports science and sports rehab, and I mentioned the term strength and conditioning. So, how do you see strength and conditioning fitting in with sports science and especially with sports medicine?
Well, they're all combined to make a beautiful mixture. Sports science, exercise medicine, and strength training and conditioning. With regards to strength training and conditioning, it looks more at, I mean, it has other aspects, but really positioning that the athlete, or position, not just the athlete, but in this context, I use athlete, positioning the athlete for optimal performance. And it does so by really going through injury prevention as well. So I heard, I think it was either Dr. Jones or Dr. Hudson had mentioned with regards to, you know, some of the typical joints that are affected in sport. So for example, the neck, shoulder, knee. When you're looking at strength training and conditioning, we do strength training and conditioning to really prevent injury from occurring and to optimize that athlete as much as possible for the particular sport. And I see that happening. There can even be like a transition period after a person would have been injured, looking at the sport medicine component of it with regards to treating that injury that's caused by that particular sport, going into sport medicine pertaining to what approach to take to properly and effectively rehabilitate that person, and going into strength training and conditioning. Now that that person has been rehabilitated, you want to position them in such a way that they do not suffer or have a re-injury. You know, I think I could be wrong, probably Dr. Jones or Dr. Hudson, one of them, they were saying that once you have an injury, generally speaking, you have a high likelihood of it reoccurring, right? Especially if you're doing a particular sport, just like what Rory Alvarenga was saying, a lot of overhead type movements, so you have a lot of shoulder injuries occurring. Right. And what strength training and conditioning will do is really condition an athlete in such a way for more energy efficiency and also for optimization and performance and reducing the likelihood of injuries occurring again with that athlete. So I do see them fit together. I see it as a transition. There can be a transition from one to the other, and just going straight into strength training and conditioning, even before a person has injury, right. You want to you train that person in such a way so that they have a very low likelihood of injury occurring. That study was done that I heard that was mentioned with Dr. Singh and Dr. Manson with netball players is in terms of the landing. And what I understand is that a lot of persons, they tend to focus and emphasize on the power output in terms of the actual jump. Jumping. But you have that power to jump, but you don't have that, you don't have that proper muscle engagement for proper control when you land. That's so there are a lot of persons who focus on the jumping and the power in jumping, but not focusing on the landing. And as a result of that, you have a high incidence of injury from landing. And what strength and conditioning will do is really prep that person so that they can land better, they can land effectively without the problem of having an injury.
Right, absolutely right. Yeah. Absolutely right. So prevention and optimization again, absolutely. Yeah. All right, over to you again, Rachel.
All right. So thanks for that, Dr. Hunter. So the next question is for Dr. Hudson. And I want to ask you, what do you believe can be done to bridge the gap between traditional practice and current evidence-based sports science and sports medicine practice in order to improve athletic performance? We know that there have been some traditional or archaic, if you want to say, beliefs in terms of how to manage certain injuries. And I give for example, you know, some persons may recommend bed rest for lower back pain, you know, for a definite amount of time with the person not engaging in any form of physical activity, only to be, you know, only for the person or the athlete to be later faced with the consequence of muscle wasting or deconditioning. So we want to find out, how can we bridge that gap between what was done traditionally and what the current evidence says in terms of how we practice sports science, sports medicine to improve athletic performance.
All right, so perhaps there are a few things that can and should be done. So I think the first thing, and it's individual. The first thing is to recognize that perhaps there is a different way. Now, you mentioned back pain and bed rest, and Dr. Jones will probably back me up in this. I hope so. That certainly when I was a medical student, and we were, that was one of the things we did, and quickly within, by the time I reached doctor and start practicing, tutus, you heard, no, we're not doing that again. This whole notion of rest up until, and it's one, a willingness to believe that there's something different and wanting to see if something different. Two, availing yourself of various different programs such as this, where you learn information. The whole reason we do continuing medical education is really for that purpose, and a willingness to change if indeed we find out that maybe what I have been doing for the last 10 years as gospel, and though it seemed to work, perhaps is not the best way anymore. And that would help. So, you bridge a gap in terms of what is being done. We put on things for coaches. It's just like us. We, as physicians, as you know, we know that within 2-3 years, what we learned 2 years ago is changed, and we have to position ourselves, or else we won't give the best to our patients. So it's changing our attitude, changing our minds, and availing yourself of all the educational programs, and being willing to then say, okay, there is indeed a better way of doing this, and I'm willing to do that. Yeah.
All right, that's absolutely.
Perhaps Dr. Jones might have a different take.
Dr. Jones, do you want to add at this time?
No, I agree. I mean, back pain is one of the big things, include, and not just back pain, but people who had vertebral body fractures. I mean, we soon realized that that once it was stable, that you get them out of bed. People used to tell people about lying on the bed for 3 months or 2 months, flat on some flat surface and don't do anything or don't roll, and pretty much live on almost an impossible life, But we know once a fracture is stable in the vertebral column, you get them up on a boat. You might give them a brace to help prevent the risk of further injury. And so on, you try and activate muscles as soon as possible, because you recognize that the critical things with muscles is that muscles support the skeleton, and if you don't use them over a period of time, they start to get weaker. And that's the whole thing with even like with braces, and like people wearing collars on their neck to support neck injuries for longer than 2 weeks. After that period of time, the muscles get wasted, and the muscles aren't able to hold the head up, and then so forth. The pain becomes just kind of more prolonged and constant and stuff. So things change, and it's important for us, based on the science, to adapt to these changes and employ them in how we manage athletes. And remember, and it's the broad sense of athletes, because I look that Ron was talking about athletes being anybody who takes part in a sport on a regular basis. I look at an athlete like a job. Anybody's job is their sport. So if your job involves you sitting at a desk for extended periods of time, you need to employ strong core muscles and strong back muscles. Otherwise you can end up with significant back injuries. So I take it beyond just translating a sport. But if you have a job that you do regular whatever, it's important that you have those muscles that you need to perform that job in good condition, so that you can perform the job without having significant consequences, neck pain, back pain in particular, and then other issues associated with it. So, yep, agreed and support.
Yes, definitely. Education plays a major role in merging the gap, in bridging that gap. And like I can give another example. This concept of relative rest is, what we as sports medicine physicians should be employing, and should help the coaches to understand, not having the athlete necessarily training through an injury, and if there's no pain, no gain. If an athlete is injured, that particular area that is injured can be rested for a particular time, but this doesn't mean that they still cannot engage in, strength and conditioning exercises. For example, in a lower limb injury, they can still do upper body work. They can still do, aquatherapy and aerobic therapy. So it's just to get your education across and on all different, platforms, to all different stakeholder groups in terms of what the current evidence says and how we practice that. So Diallo, back over to you for the last question.
Sure, last question, but Rochelle, thank you for that point. That actually kind of segues into my last question, and this is not for Dr. Jones. So Doc, so of course, we are a sports clinician, but of course you coached field events, so you're also a coach. And because you're a coach, that means you speak coach, if I could say that. You speak the language of coaches. I mean, the clean version, of course, but you speak the language of coaches, all right? So, and you also kind of understand the coaching mindset, having been a coach, and of course, a retired athlete, as I said. So this question is two parts. Part one, how would you advise fellow clinicians to bridge the gap in terms of communicating with other coaches? Of course, for the best working relationship with the coaches and for the ultimate positive outcome for our athletes. And then part two, kind of flipped, what would be your advice to fellow coaches in terms of seeking that good working relationship with sports clinicians and so on, especially the clinicians don't naturally speak coach in the same way, or be your advice to fellow coaches? So two parts of that.
All right. So advice to physicians first. Yes. What do you say?
To clinicians, yeah. So whether physios,
yeah. So advice to clinicians is really first to listen to what the athlete is saying. History and examination becomes very important. This is what the athlete is saying, and then see if you can work out in your headspace based on your knowledge what the underlying problem is. So like I've seen athletes coming from elsewhere. There was one guy in particular, I remember he had a stress fracture of his talus, which never made sense. In that it didn't make sense, I didn't have it. But he had a stress fracture of his talus, but that's very uncommon, So the fact that he had that would suggest that there was something going on with his foot, and that he was actually running on the outside of his foot. That's what the evidence suggested. And so when I went further into his history, I realized he had a first metatarsal, he had a big toe problem. So he actually had a stress fracture of his great toe as well, which was causing him to run on the outside of his foot and causing him to have the stress fracture of the talus. So sometimes we just see and we're quick to make a diagnosis and jump in and start treating the problem that is there, the problem that presents, and not looking for the underlying cause and realizing that there are other issues that would have predisposed to that problem. So that was a prime example where you see an unusual problem and you don't just treat it as stress fracture of the talus, you treat the stress fracture of the talus. That's unusual. Why are they having this injury? And then it would suggest you're doing this. And when you investigate, you find that they are doing that, then you try and correct that. So listen to the athlete and look beyond just treating the diagnosis that is either presented to you from somebody referring the patient, but look and see what are the factors relating to that, and then try and correct those factors, which will help you to correct the primary problem essential for, plus the secondary problems causing it, and overall enhance their performance and their outcome. And then how you said to coaches, you said, or to
so other clinicians and how they relate to the coaches, and then
the coaches, yeah. So you have to kind of know where a lot of the coaches are coming from and speak the language of the coaches. So I recently saw two athletes at a particular school, and one of them was a thrower, which is my thing that the throws coach, the other pretty tight from way back when, I think. So I could relate to him directly. She was having the issues that she was having was a knee problem, which was as a result of her blocking with the left leg, the right-handed thrower. And she's having that issue inside her knee. But to overcome that problem, though, it's important for her to throw without blocking on that side, without using that leg to prevent forward motion. And so she would have to become what we call a recovery thrower, which he understood directly. So if you know the sport and you know the language, you can speak directly to the coach to let them know, so, all right, let's not. So she needs to go from a non-recovery thrower to a recovery thrower. And he generally coaches throwers to not recover, you know? So, speak to the coaches directly if you try to understand what it is that they're trying to do, what they do normally. And most coaches recognize that there's more than one way to skin a cat. And then once they recognize it, all right, well, this is not good for her, they'll switch accordingly. So you have to try and understand the sport, understand the factors that go into achieving the performance and the factors that are being exacerbated by the injury, and then how best to overcome that based on the confines and the recommendations of the sport and still achieve the optimal, the optimum outcome.
Right. And then, so what we say for the coaches now, so they're dealing with a clinician who's not as familiar with the sport. What would it be your advice to the coaches? So, take time with them.
The coaches, well, again, coaches need to listen to their athletes and don't assume that things are headspace. What they need to listen to athletes. Assume that what they are saying is true. Have it checked out, and then evaluated by somebody who knows more about that side and support. If it turns out that the person finds nothing, they might prove your point. Like they might prove that the person. Some coaches think that some athletes are head cases. I found out with one of our national prominent athletes, coach thought it was a head case. He tried to have an intrinsic problem, which we corrected. And he went on from never winning an individual medal to winning an individual medal, just from basic science. So the coach thought it was a head case, where he would cramp up in the final. The whole thing was a head case. Evaluated him. It was not a head case. He had legitimate reasons for having the problem. Advised the coach, advised everybody accordingly, putting measures to correct the problem. He went on to do well in the sport he was doing and went on to win an individual medal at the next World Championships after that one that I intervened. So coaches need to listen, and regardless of what you feel, it's best to get an independent opinion to assess it and decide whether, it's a head case, you don't really find anything. And if it's a head case, then we will say, this is the issue. I send them on to colleague and friend, Jason Scott Hamilton or Olivia Rose or somebody to deal with that situation, So let us get in there, assess it, don't write off the athlete and decide what the issue is. And if it's something physical, we can usually correct it and advise our colleague. If it's something mental, we can advise them and point them in the right direction as well. So don't just write that off. Listen to them, act on what they're saying, get it evaluated and sort it out. And that's the best way I find to achieve optimizing their outputs and their performances.
That's good stuff. So it's really being open-minded, listen to the athlete and so on.
It's being open-minded, and following it through. And look at all the facts based on the science and say why this is unlikely to have this problem with this. This is a more likely problem. Like you're more likely to have hamstring issues with a lead leg and groin issues with a trailing leg if you're a hurdler kind of thing. If you find it's something that's going on, the opposite to that, look for why that's going on and so forth, I think, but follow it through, we will address it, do the science, and then advise accordingly. I mean, some of you won't be like, but most athletes, we're usually able to help in some way or form, either by determining that it is a problem, it isn't a problem, or point them in the right direction.
All right, excellent. Thank you very much, Dr. Jones.
Right.
All right, Rachel, I guess we can open to the audience. I know we have at least two hands.
Dr. Fiala, there is a note here from Dr. Scott Hamilton. He said that a comment, are we also as a JSM engaging the science with the experts in their proven fields? I am speaking about people like MVP Francis Brothers and their teams, and say Kerry Ricketts for triple jump as expert coaches and coach Rory Alvarenga from swimming, for examples, who assist their athletes in proper form to minimize injuries. So the question is, are we, the JASM, engaging the science with the experts?
Well, I would say briefly, I think that's what the link is aiming to do, or one of the things the link is aiming to do. Make that connection and maintain a connection with the coaches and all that stuff. So I would say that's what we're looking
But we do. Yeah, but we do, because a lot of these coaches contact us in different ways or form, and we link each other individually. Yeah, a lot of these coaches contact us in all the names we call, and including others up and coming. You know, in fact, one up and coming who has one of the top national athletes now. We have to work through his basic problems and sort out his injury for him to go and perform at the level. So we do. A lot of us travel with them, we engage them at the time. Some of them call us and we talk to them directly and so forth. And if not, somebody calls somebody, and then somebody will call somebody else and ask. You know, like you have dialogue about a lot of the swimmers and so forth, and the power lifters and so forth. We have dialogue about different aspects in terms of strength and conditioning and so forth, I think. So they do. We do engage them where once they reach out to us, but we don't jump in and intervene and say, oh, here's the solution, here's the issue. We usually wait until it comes up and then we engage them, but we do.
Mr. Alvarenga has his hand.
Yeah, it's a problem. I think Mr. Johnson somewhere.
So you could go ahead, please, Mr. Alvarenga.
Thank you, everyone. I don't know the names a lot for the persons in here, for over 53 participants. But Dr. Jones, I guess coaches have some head issues too, and we need to seek Scottish sometimes, But as David said, it is the black line swimmer or the lane athlete that usually comes seeking the help. I've seen David on all these courses and other platforms I've shared with him. And yes, because that individual athlete, Diallo, we're on board. And you shared with me recently, strength training. It improves the neurological factors, supercore strength, utilizing the Olympic lifts and so forth, which is usually a part of every sport. Swimming in particular utilize a lot of core. But yes, so we need to get involved with more of the sports medicine. And as I asked, who is assigned to swimming? Not yet. It's new. The link concept is new, but I look forward to bringing in all the material. I did make a comment in the chat that, sports science take the guesswork out of performance and get the results in there. I have, a testimony to this, of course, with Dr. Rushal out of San Diego University. It's not a question, it's just a big up to the Jamaica Association of Sports Medicine, Scotty, Dr. Raman, James, Olivia Rose. I have worked with all of y'all, tremendous results from my athletes, and we look forward to the collab with everybody, Professor Rachel Irving, in getting Jamaican athletes to the next level, injury-free, and performing and breaking world records.
Amen.
All right, thank you, Coach. I had seen a hand earlier from, I think it was Mr. Johnson. I'm not sure if he still has a question there, or if there are any other questions from anyone.
I'm not seeing any questions. I think I think a lot has been said, and maybe the areas have already been covered.
Right, possibly, yes. Hold on, I see one question from. Yeah, I see one question.
There's one up now. There's one up in the chat now.
So Mr. Raheem Wallace is asking, how involved is the JSM in college sports injury prevention and athletes performing at optimal? And athletes performing at optimal, and what methods are used to gather some of these data? So how involved is the JSM in college sports, injury prevention, and optimal performance, and what methods are used to gather some of these data? College sports, that's actually a good question. I think we have tended to be, well, I guess if we're invited as an association, we tend to cover the events, right? But I think we tend to cover most of the high school events. I know we have begun collecting data. especially through Mr. Miller. We were collecting data, injury data from track and field meets and so on in particular. And I think some swimming as well. So that is something that we've begun in terms of collecting data and so on. But as far as I know, in terms of college sports, I'm not sure if anyone else from JSM wants to speak to that.
Well, I
we
mean,
tend to cover high school. Yeah, go ahead.
We have started the periodic health evaluation as an initiative.
So that's one reason.
In terms of, injury prevention and screening. So that is how we see where we could engage this sector of athletes and hopefully expand that in the years to come.
Right. Hopefully the coaches, of course, will embrace that as well and embrace it readily as well. All right. I'm seeing 2 comments here. So Dr. Hamilton saying, I know you do, I guess you're referring to us as JSM, I guess. And you've seen it firsthand, Dr. Jones and myself, from both of us when we travel. But of course, as you said, Jamaica competes in many sports, so you're checking on all the other sports. And Dr. Jones, let's say we're seeing that other sports can be challenging, as some of them have their own persons, one not necessarily have the same. They're not part of the association, which is true. That's why we're trying to reach out to them. And of course, may not be of the same mindset. So again, that whole open-mindedness thing again. So yeah, we do try to make ourselves accessible to everyone. All right. Anyone any further questions? We just have a few minutes left.
What I find is what we're doing here with regards to JSM is pretty helpful. Is a very helpful way of getting across information.
Right.
You will have some of those coaches who may have their own methodology. I may think that they're fine and that they may not want to be a part of seminars or workshops and want to do their own thing.
Right.
But I think as we continue to push activities or events like this, more and more persons will be informed and educated pertaining to the coaches. And the coaches, they do talk with each other. So I believe that as you continue in terms of this committed effort, you will get more and more in terms of the coaching. And one thing that I do, I'm not sure if it has been done, but have you been keeping like a list of coaches, like a pool of coaches so that you can contact them when we have activities like this? Do you have a pile of coaches?
I think someone do. I think our secretary has like a set list that whenever we have, for example, these keeping pace seminars, she sends us straight out to certain coaches or to certain sporting federations and stuff like that. I do think we do something along those lines. Right. But yeah, that's I guess a great point. Thank you for that. All right. So that sounds like no further questions. We're right at 2 minutes to 5. Not too bad. Hold on. One more question coming in at the last minute. All right. So here's a question. I'm going to put the question so somebody else can answer. So the technology associated with sports medicine is said to be expensive. What support can the association, I guess that's us, give to sport organizations, and how is the Jamaica Association of Sports Medicine, I guess, funded? So I'll let maybe the president and former president speak to that. But again, the technology associated with sports medicine is said to be expensive. What support can we give to sport organizations, I guess, in terms of the technology, and how are we funded? Yes, Madam President.
Well, perhaps the most immediate support we can give is by education and a willingness just to lend or physical support. However, we are not, the question is, how are we funded? We get a grant from the Sports Development Foundation. That is our major source of funding at this time.
I'm not seeing you. Are you there? I'm not seeing you.
My camera malfunctions, so it goes off sometimes.
Oh, okay.
Right. So our major source of funding is the Sports Development Foundation, and we do sometimes from time to time get some funding from things like these, but we are not a profit-making organization. That is not our aim, and therefore the expense that might be required, as you put it, and yes, we do know some things are expensive, cannot come from us, unfortunately. Perhaps a few years later when we are, if we have a nice I don't know what to say, but we can't do that, right? Well, benefit, I was going to say a boobs, but then I thought it might date me. But yes, so we can't lend that support. The most we can do at this time is in as much as we're able is to give our expertise in service. But again, that too is limited because we have our own jobs to do. So what we are hoping is that by educating and doing what we can. So for example, the periodic health evaluation, I keep coming back to it, not because it's novel. There's nothing novel about it. But from our perspective, it's one new way that we can try to reach out to persons, particularly those schools who we know would not ordinarily be able to afford an ECG. So we target those schools because so we're trying in that way. And that is what you might call low-lying fruit. But even so, if you look at, it is expensive, and an ECG in and of itself is not a cheap thing. So we can't do it, unfortunately, at a very large scale at this time, except provide our expertise, which we're willing to do. Yes. But if you know somebody who would love to give us some millions, please point them to us. We'll be happy to assist and manage it for them.
Yeah, can I interject here just a second? The issue with the expense, we recognize that a lot of stuff is expensive. But one thing we can do, rather than talk about education, is not just to educate how to deal with things, but also inexpensive options to deal with the issues at hand. There's a lot of hype of stuff and a lot of technology out there to do certain things. But remember basic things like free weights and stuff like that thing been around forever, and if used and employed appropriately, can produce the appropriate results that you need. So you don't necessarily need to have all the latest technology and support to perform well. Use what you have and just know how best to optimize it, and that's where we come in. That's where we come in with stuff, because we recognize that we ourselves do have access to a lot of stuff, and so too do many other artists, but we can help you to achieve the utmost by employing something that we do have access to.
All right. Thank you, Doc. Thank you very much. All right, ladies and gentlemen, I'm going to wrap up here. We're right at the 5 o'clock mark, past the 5 o'clock mark. So just want to thank everyone for attending. Definitely thanks to each of our presenters. Dr. Rhonda Hudson, President of the JSM. Thank you very much. Mr. Fabian Miller, Education Co-Chair of JSM. Thank you kindly. And then our panelists, Dr. Jones, Dr. Kevin Jones, Dr. Raman Hunter, Dr. Hudson again, of course, Mr. Fabian Miller again, and Coach David Valley. Did I miss something else? Thanks, everyone. All right, thank each of you for attending, for being here for this long, and for really sharing your perspectives and so on. Thanks, of course, to the audience for attending. We thank our sponsor, our regular sponsor, About Nutrition. Thank you, Mr. Paul Russell, for being here. And I'm not sure if I'm missing anyone, but definitely thanks to everyone. Thanks to all who actually helped to make this seminar possible. So, Education Committee persons, Dr. Joe Rattray, big up yourself as usual. All right, we have our young lady here, Ms. Tajari Sims. Thank you for being here and for assisting us. And yes, thank you to also thank you to our YouTube attendees who actually were here as well. So just thanks to everyone for attending. This is our last Keeping Pace seminar for this year. Our next one will be next year in March, I believe. The central branch of the JSM will be doing the next Keeping Pace. So you guys can keep in touch or stay tuned for information on that. We put that out in due time. All right. So other than that, just thanking everyone for attending. Thank you for making yet another good and successful seminar, and wishing you all the best. And all the best for the holidays when they come.
Bye. Remember CEUs.
Yes. Oh yes, CEUs will be, so for members of JSM, you will get a CEUs once we have attendance confirmed. Persons who are non-members, this goes to those YouTube persons as well. If you're a non-member, please, in fact, let me put it in the chat right now. Please email So you're sending 2 emails. So I'll put it in the chat. You want to email the education committee of the JSM, and you're also going to copy the Jamaica Sportsmed email. I'll put those in the chat shortly. So if you're a non-member and you wish to obtain CEUs, send the email to us. You need to provide proof of payment. It's $1,000 for the CMEs now, $1,000 for the certificate. So attending is free, but $1,000 for the CME certificate if you're a non-member of JSM. If you're a member of JSM and you're here, you receive your certificate for free. All right. Look out for certificates over maybe the next 2 weeks or within the next 2 weeks thereabouts. Put those in the chat. So thank you everyone again. I'll put those in the chat. And, enjoy the rest of your Sunday.
Remember, folks, for your basket, your gift baskets.
Oh, yes.
I mean, I'd love to keep them. They're really nice. But please get in touch with me. Might have to set up a central location for you to do your collections, to collect.
I've heard this is what state. It said what stay too long, serve too. Oh, sorry, let me stop. Okay.
Serve not a man.
Oh, my mic is on. No, sorry, beg your pardon.
Good night, all. Thank you. Great presentation.
Thank you very much.
Great. Well done, everyone.
Thank you.
Well done, Mr. Diallo, and all the rest of the education committee. Well done.
Thank you very much.
Other good KP presentation.
Thank you very much. Let me put this out to the chat, and thank you. Thank you, everyone.
Bye-bye.
Thanks.
Stay safe.
Bye. Bye.
Keep safe, everyone.
Bye, everybody.
Bye, Doc. All right, so I'll leave the chat. I'll leave the Zoom open for a while, and you guys can see the information for the emails. I want to email both email addresses. So the education email, and please copy our main Jamaica Sportsmed email. Person in YouTube, I'll put it there as well. You gotta just copy and paste. All right, we'll close in about 1 minute or less. Thank you, Mr. Sinclair McDonald. Same to you. All right, gonna close the meeting in just a few seconds. Thank you once again.